Chapter 28, Wound Management and Bandaging. We're going to talk about the phases of wound healing first. So you need to understand how wounds heal in order to understand how to treat them. You can also do a little bit of forensic investigating if you see a wound. The owner tells you that it just happened. You can actually look and see, are we in the inflammatory phase, in the proliferative phase, or actually in the maturation phase, and say, I know that the maturation phase doesn't happen for at least a couple of weeks, so this probably happened a while ago. We may have to treat this a little bit differently. So the first phase happens the first 3 to 5 days, and it's called the inflammatory or lag phase. This is when we have the initial healing, so that we have a clotting cascade, so the platelets come in and keep it from bleeding, right? We get a clot. And then we have macrophages and neutrophils. They're the first part of the immune system that come in and start to take away all of the bad guys, the bacteria and the debris. At about 2 to 3 days, we start to see the result of that clearing out and starting to heal. We get the proliferative phase, and it's overlapping with that inflammatory phase a little bit. During the proliferative phase, we get fibroblasts and growth factors. Some collagen comes in. We start to see granulation tissue. I'm going to show you a picture of that in just a second. That granulation tissue is really well vascularized, and so it continues to bring all of these collagen factors in. And then we start to see epithelialization. The epithelialization is basically the skin growing over top of the granulation tissue. And with that, we'll start to get wound contraction. Wound contraction, when you start to see wound contraction, you're seeing the maturation of the wound. We're getting a remodeling, a realignment of those collagen fibers. First, when they first come in, they're just kind of shooting in there and they're every which way, and then they start to line up nicely and they contract and you're starting to get a scar. That's when we start to gain our maximum strength. Let's take a look at this picture for a second. Here's the initial wound. It's probably could be a day or so old, maybe a chemical burn, some type of burn, something like that. So it needs to be debrided. This is all black tissue, is all necrotic tissue. There's probably some dirt in there. We need to clean that up a little bit. We can actually see some epithelialization happening here. Okay, so we know this didn't happen just today. This happened a couple of days ago, at least 2 to 3 days ago. Okay. Once we get this all debrided or remove the dead tissue and any dirt and debris that's in there, this is what it may look like. This is a good bed of granulation tissue. Let's go back and look. Granulation tissue happens at about 2 to 3 days and can be there for several weeks. So we're starting to see epithelialization and granulation tissue. That's a nice bed of granulation tissue. This is a little bit deeper. We don't have the granulation tissue all covered in there, but it is starting to come across the wound. Here is the granulation tissue, nice and pink, lots of good blood vessels there, and more epithelialization. This crusty stuff at the edge of the wound, that's serous material, it's serous fluid, it's normal. The body is pushing blood through these small vessels, and some of the liquid is going to leak out. That serum that you get when you spin down the blood, that's the blood cells get stuck here in this wound, and the serum stuff comes out. That's normal. We are getting further maturation here, the epithelialization, and you can see it's getting smaller and smaller. Now here's the issue with this type of wound, however. It's kind of a round wound, and round wounds heal from the outside, or any wound heals from the outside to the inside. And if you have a round wound and you're constantly healing from the outside to the inside, outside to the inside, outside to the inside, it's just going to get us to be a smaller and smaller circle. Eventually, we may actually have to make a fresh cut in there and bring that together as more of a square or a line so that those edges will come together. Because remember, circles don't have edges. Some things that influence wound healing. Some patient factors. The older they are, the older they are, the longer it takes to heal. If they have an orthopedic or neurologic problems, it'll take a little bit longer to heal. If their nutrition status is bad, we need nutrition for those healing factors. Wound factors. How did the wound How is the wound made? Is there any contamination of the wound? Bacteria infection stops the progression of wound healing. We also need to think of any other concurrent treatment that we have to do. If we're giving corticosteroids for another treatment for severe inflammation, that's going to delay the phases of the wound healing. So infection stops the progression of wound healing, corticosteroids delay it. If we can use proper care, we can eliminate many of those wound factors. One of the things that is really cool, most things that you apply to wounds will actually delay wound healing. The body loves to heal itself, and it's really good at doing that. And if you apply bacitracin and other ointments, it actually will delay the healing of that wound. The only thing that you can add to a wound, actually, there's just a couple of things, but one thing that is really cool is honey. Honey added to the wound will actually improve the healing process. It's anti-infective, and it's antifungal, and it actually creates an environment that is healthy for the wound. We do have to remember that if the animal's undergoing radiation therapy, that is going to also negatively affect wound healing. So an animal with cancer, if they have a wound, that's going to be a bad combination. When we're managing that wound, first we need to stabilize the wound, make sure that we're stopping the bleeding and stopping movement around that wound. The more that the edges of that wound move, the more it breaks apart that granulation tissue, and then it has to reform again, and it just delays it. So we want to stabilize that wound. We want to prevent contamination, so we want to try to keep it clean as possible. That might mean bandaging, which we'll talk about in a few minutes. We also need to clean that wound and lavage it. Here's a really good example of how to clean a wound. We're using a big bag of fluids. This is a 500 ml bag of fluids. We've got an administration set. It's set up to a 3-way stopcock here, and this is a 3-way stopcock because we have 3 different ways that this fluid can go out. This is a syringe and a needle. What we can do is we can draw up fluid, we close it off to the needle, we draw up fluid into the syringe, close it off to the bag, push the fluid out of the syringe. That creates a nice stream to really debride and remove any debris in the wound. Think about a pressure washer versus a hose. Which one is going to get your house or your sidewalk cleaner? The pressure washer. So this is pressure washing the wound. Wound debridement is when we remove dead tissue or tissue that's not helping in the process of healing, or infected tissue. It can be surgical, which is shown here. It can be enzymatic, which is using a chemical to break down dead tissue, or it can be mechanical. It's just mechanical means we're scrubbing the scab and bad stuff away. It can be staged, and I'll show you that in a minute. So we can clean the wound first, or use enzymatic cleaners first, and then in a couple days, as the wound starts to come together a little bit, we might do a surgical procedure. This is an example of an unblock or whole amount of tissue coming out. Is coming back out as a block, and what we do is, this is the wound, the infected wound here. We're going to go to the healthy tissue outside of the wound. We're going to straighten out those edges a little bit, take that whole wound out, and bring this surgical closure together. And that's the best way to heal. If we have a surgical wound, that's the easiest way to heal a wound. So these are the different closures. The primary closure is like a surgical wound. If we have a laceration that is very clean, or we can clean it up, and it's a straight laceration and we can suture it, that is a primary closure. In some cases, we have to do an open wound management. This is healing by primary intention or primary closure. The second line is healing by second intention or open wound management. We are not going to close this. We are surgically not going to close this. We're going to allow it to close on its own so it heals by second intention, or as an open wound. We're allowing this bed of granulation tissue to build, and then this skin is going to epithelialize over top. Okay. We do want to make sure that it's healing from the inside to the outside so we don't trap any bacteria inside there that's going to cause an abscess. This is a wound that is deep and is wide and maybe causing some extra issues, and it's enough that there may be bacteria in there, so we want to allow it to be open and heal from the inside first before we close it. So we allow this granulation tissue to form. When it gets to the point where it's closed down enough, we may freshen the edges a little bit. So freshen the edges means we rub the edges, get the blood flow going, and then close it with a suture. So hold it together with suture. Here it is in real life on a person. Really big wound here. We need to leave it open so we can clean it, allow it to drain. So we're going to allow it to granulate in this deep tissue and then slowly bring that together. These are laces that can be tightened over time. So we can bring that together so we have a smaller scar there. And this is called a secondary closure, more a healing by tertiary intention, meaning we have 3 steps. This is the open wound, heals open, we have open wound management for some time, and then our 3rd step, our tertiary intention, is to close it surgically. A change in the status. And so what it will do if there's a large mass there is once you take that mass out surgically, if you leave too much space in that area, it will fill that space with serous material. So that same fluid that's in your bloodstream, that if you spin it down, you get the cells out of there, that same fluid will come in and fill that space. So if we want to keep that from happening, so if that fills with fluid, it's not going to heal as fast, so we want to keep that from happening. We actually want to put a drain in there. We can also do this if we have a wound that may be infected. We want to drain that material out. The most common one we use is called a Penrose drain. It's this flat latex material, kind of a ribbon of latex. And we put it on to the side of the wound, not in the wound itself, but to the side of the wound. We need that laceration or that surgical incision to heal. And we're going to allow that stuff to drain out so it's not stuck inside. After about 3 or 4 days, we're going to take that drain out, and that should heal nicely. If we have something that is putting forth a lot of fluid, we're going to use an active drain. It's also a little bit cleaner. We're going to put it in, this is put in surgically, aseptically as well. This one we can keep aseptic. This is just hanging out there. This one we can bandage up and keep aseptic and keep in for a little bit longer. So we can use a closed suction, a vacuum action, or a rigid fenestrated drain like this here. Wound infection can be an issue. Obviously, infection stops healing. Some signs would be swelling, a yellow pussy discharge, redness, pain. Those are all indications that we have infection. This is a very severe infection. That's a very deep pyoderma or pus in the dermis. That helps us to determine what we're going to do to treat it. We can do oral versus IV antimicrobials. In this case, this is going to be definitely IV because this is probably systemic. We need to culture the organism to see what kind of pathogen we're dealing with so we can get them on the right antibiotic. If it's a mild infection, we may be able to use a topical antimicrobial. There are different types of wounds, and of course, different types of wounds require different treatment. Abrasions are just taking off, it's like skinning your knee, taking off the first layer or so of the epidermis. Lacerations are cuts. They're like cuts. They're not really cuts, but they're like cuts or slices in the skin, and they can go to deep tissues. Most lacerations are actually caused by blunt force trauma. So you hit something so hard, it actually breaks it apart and rips it. That's how most lacerations are made, and that's why when you see a laceration, it typically looks kind of jagged. It just breaks along the skin. It's not sliced open. A degloving injury, I'll show you in a picture in a bit, a degloving injury is when the skin is actually completely ripped off from the hypodermis all the way down, exposing muscles, tendons, bones. And it can happen in a number of different places. It takes a lot of force to do that, so it can be pretty devastating. Bite wounds can be a problem because they definitely go deep and cause deep tissue damage. Burns, decubitus ulcers, which are caused by, typically start with pressure sores. Pressure sores that are not being managed appropriately, caused by staying in one place over time, and the blood stops flowing to that particular spot, and then we lose tissue. Dead tissue leads to the decubitus ulcers. We want to maintain a moist wound environment that will help to speed the epithelialization, and it's preferred over actually allowing the wound to dry out and scab over. So wearing a Band-Aid actually heals your wound faster. It's an example of a degloving injury. We have a large section of skin that's torn off the underlying tissue like a glove. Okay, this is a jaw. This cat does not have its mouth open. The skin has been torn from the jaw, and this would be from a hit by car, skidding face first. Bite wounds are challenging to assess because this can be really extensive injury down to the deeper tissues that you can't really tell by these two little puncture wounds on the skin. Depending on the size of the other dog, we may see it go very deep into the tissue, or it could be just a little bit. We always have to look for 4 holes though. And actually I can see 2 more small puncture wounds here, but I want to be able to look for 4 holes where all 4 canines went. Burns are classified on the basis of how deep into the tissue the injury reaches and how large the affected area is. This is going to be a severe burn. We are burning through the skin that's black and charred, and it's burned all the way down into the deep tissue. This is a decubitus ulcer, usually over a bony prominence as a result of skin compression on a hard floor if they've had long periods of recumbency or haven't gotten up in a while. Some principles of bandaging. Bandages are applied to manage soft tissue injuries, but also to stabilize bone and joint injuries. Bandages consist of 3 layers. The adherent primary contacts the wound. It's not necessarily sticky, it just is directly in contact with the wound. Non-adherent primary provides padding to the bandage, and the tertiary protective holds and protects the other 2 layers. Here are an example of 2 very common bandages, the Robert Jones and the modified Robert Jones. The modified Robert Jones is the one that I most commonly see in small animals. The Robert Jones, the difference between the 2 is this has a lot more padding. Now, the amount of padding typically should be enough that it is a complete round circumference. You're not really even seeing a joint or a divot here at all. This could be a little bit more padded as a bandage. This is a little bit more conforming and a little bit more tight to the skin. So when we put on a Robert Jones bandage, there's actually a step missing here. In order to keep this bandage up on this limb that is moving and he's standing up on it, we need to keep it in place by using stirrups. Stirrups are tape strips, one on either side of the leg, that we will put on the length of the leg and bring it down past the end of the leg. We can use that as kind of a handle to pull the leg out straight, so that helps us to straighten the leg as we put on a Robert Jones. We apply several layers of bandaging, we can take those tape strips and turn them around and pull them up, and they actually hold the bandage up in place. So that's the first thing that we'll put on. If there's no wound, we can actually start with cotton padding. If there's a wound, we're going to put a Telfa pad or some type of bandage material directly on the wound. This cotton padding needs to be put around very smoothly. We don't want any wrinkles because that is painful and really uncomfortable when you have a cast. After we put this cotton padding around, we're going to put some gauze to smooth that out and give it some structure. And then this is Coflex, it's just a self-adherent bandaging material. You have to realize how much cotton is in here. There's a lot of cotton in there, and this is not a waterproof bandage. water will go through there, soak through all that cotton, go right to the skin and stay there, and this outer portion will get dry very quickly. So people will think that their animal's bandage is dry when it's actually soaking wet and touching the skin inside, and that's very dangerous. Casts and splints are used to provide stabilization and support for joint injuries, or for temporary support until we can do surgery. Sometimes we can use it for a definitive treatment, meaning this is the way we treat it, or if we need to stabilize after surgery. These splints are only for injuries below the elbow or the stifle, and here's the reason for that. Any injury we have, whether it's soft tissue or a joint or a bone, we need to stabilize the joint below and the joint above the injury. If we don't, then we are not making sure that that injured area stays still. We need it to stay still. So if we have injured our humerus, it is very difficult to, which is our upper arm, is very, very difficult to stabilize the shoulder. So a splint wouldn't help. We'd still be able to use the shoulder. We would have to use a special sling or a body cast in order to stabilize that. So all these splints are for anything below the elbow or the stifle. These are prefabricated splints, and we can actually break them at these lines here. Those are breakable points, so we can get them to fit just right on the animal. The spica splint is much like you would see a finger splint, so it is a straight splint that has padding on one side. Sometimes we have to use slings in small animals. I'm going to name these slings, and I'm going to expect that if I show you a picture of them, you'll know what they are. This first one is the Ehmer Sling. This goes around the upper leg and around the foot of the animal in a figure-8 pattern, and it keeps the animal from stepping down on this foot. So they can still move that hip, but they can't put any weight on it. It's similar to the 90-90 flexion, but if you notice the difference, we have this going straight up and down here, and this going 90 degrees to it. So this puts everything in flexion, and again, it keeps the animal from putting their foot down, so no pressure on the hip. So it protects the hip. So Ehmer and 90-90 flexion protect the hip. The hobbles over here also are typically used for the back legs, and it's just keeping those legs at a good angle from each other so they can't splay out, so you can't have an animal fall down with its legs splayed. That's called the hobbles. The two for the front leg are the velpo, which straps that leg straight up right next to the body wall and keeps it there. It keeps the shoulder from moving. To avoid putting any pressure on the shoulder can still move in this case, but to avoid putting pressure, we can actually take the carpal and bend it, the carpus, and bend it, and put a bandage around it, tape around it to keep it in that position. That will keep the animal from being able to extend their elbow and put weight on that leg, so no weight on the shoulder. So here again is the Ehmer Sling, and I have found in my practice that it is very helpful to be able to put something up around the abdomen as well to keep it in place. You can see padding here so that we're not cutting off blood vessels in this very bony leg. And this is a sticky bandage that is put in a figure-8 pattern around here. It's going to keep it in place. Some other bandages for other locations. There's this tie-over bandage in which we put a bandage and then put sutures around it to keep it in place. This is under the arm, so a very difficult place to bandage without it bunching up. We can use an adhesive drape like they use for surgeries. Obviously, the animal would have to be shaved to apply it. We can use a 3-layer soft padded bandages that are readily available or commercially available. We can bandage around the chest or the abdomen, completely around it. Tail bandages are also difficult to put on. If you think about the animals that have tail wounds, they're usually very happy animals that wag their tail a lot, and they've banged it into something and created a wound. So what we have to do with that is do the stirrups, use the stirrups to keep that bandage in place and not allow it to slip off, much like we do with a foot bandage. So wound management aftercare timing, we have to be careful that we don't immobilize joints for too long. They'll become very stiff and hard for the animal to use. We also have to make sure that we're letting the owner know when we might need to do bandage changes. If everything is going well, I might go, and I don't have an open wound, I might go as long as a week before changing a bandage. Typically, I'm going to want to see them every 3 to 4 days to change a bandage, especially if we have a wound. We do want them to limit exercise. We want them to monitor those bandages. Hey, sometimes we put bandages on too tightly, we get a wrinkle in the bandage, it's uncomfortable, or hey, the animal went outside and there was dew on the grass, we forgot to put the Glad wrap or the plastic bag on, or now they're chewing on it. We want them to look at the toes to make sure there's still blood flow going to the toes, they're not swollen, they're nice and warm. We want them to watch these things so that they can come and get a bandage change when it's needed. If they don't, they can actually make things a lot worse. Wound care on horses is a little bit different, primarily because it's a bigger animal. We typically don't put them under anesthesia. We typically do a local anesthesia and a little bit of sedation in order to fix wounds. So here's an example of putting a local anesthesia around a wound. One injection that we typically do with any animal, large animal that gets a wound, especially horses, is we'll want to give them a tetanus toxoid or a tetanus antitoxin to make sure that they're not going to be contaminated with the tetanus toxin. Horses get proud flesh. This is exuberant granulation tissue. They're really, really good at making granulation tissue. So any open wound, especially ones that are in an area that moves a lot or is getting kicked a lot, they love to make granulation tissue. So anytime there's any break in the granulation tissue, it just makes more. So we want to immobilize the limb, maybe bandage that wound. We need to take that granulation tissue off because the skin is not going to be able to epithelialize over top of that. So using cryotherapy or electrocautery to remove that tissue. Bandages for horses are very common. We do a lot for lower limb support and also if we have a lower limb wound. So this is just these are polo wraps. This is supporting these tendons that are holding this animal up. We'll do lower limb support if we're traveling very far or if they're doing a hard workout or something like that. We're always wrapping in the same direction, and if we're wrapping for this tendon, we're going to start up here. If we're wrapping for even a lower leg wound, we actually want to start below where the hoof starts. We don't want to let it come just to the edge. We can come up here, but we're going to start to cut off circulation if we go not low enough or too low or not low enough. So right about here, if we leave the bandage right there, we're going to cut circulation off to that hoof, which is bad news. So here's a non-adherent dressing over top of a wound, like a Telfa pad that's not going to stick to the wound. So we can allow granulation tissue to grow unmolested. And then we're going to roll some conforming gauze and go up and above and below the wound edges. And then we're going to immobilize that. So we're going to go up and up above the carpus and down below. Here are some bandage materials that we use for horses, some tape, a Telfa pad or a non-stick wound pad, some rolled gauze, some outer bandage material, some rolled cotton material. So there's a lot of different types of rolled padding here. It could be rolled cotton, layered cotton sheet, quilted leg wraps. This is a military field bandage. A lot of different options. Here's an example. We've come all the way down past the hoof, so that's good. And we've got the cotton. We've got rolled gauze over the cotton, and then we've got a tertiary bandage over top. And we can use ace bandage or a track wrap. And we use it in a barber pole fashion. So every wrap that we do is going to cover that last wrap by about 50%. Okay. So here is the putting the quilted pad, doing the cotton gauze, and then doing the the elastic on over top of that. And then we may tape above and below just to keep it in place. This is nearing where I would be very cautious about how low I've placed it. I may want to suggest that we go lower to the hoof wall there. Splint application. If we have to really stabilize the leg, we have to use something like a 2x4 or a PVC. If we have a tendon laceration or a flexure deformity and folds, a lot of padding, and then this is duct tape. One of the most common things we'll do with cattle is to apply a claw block. A claw block is like a high heel. It takes the other claw off the dirty floor. Basically, we're applying it to the unaffected claw or the healthy claw, and it keeps them from weight bearing on that injured claw. This is just an example of some of the ingenuity that we have to use with larger animals. This is a modified Thomas splint. We have to use hardware to fix them. So construct a metal ring, and we have some metal tubing that comes down. We're going to fasten that metal tubing and drill through the hoof itself in order to fasten to it, and then we're going to also tape this directly. We're going to cast this leg and then tape it, and that's going to create a really good and very sturdy place for this calf to walk. Okay. Any questions, please bring those to class. Please write them down. A lot of information on wound healing. I do have a story for you in eLearn that just is a kind of a silly way to understand the different processes of the wound healing in just a different way. Sometimes you have